The novel coronavirus pandemic has brought lots of questions and uncertainty this year. How is the virus transmitted? Am I at risk? What is safe to do? But beyond those immediate concerns, this pandemic is changing our lives forever in ways we are only now starting to grasp. I'm Jennifer Stayton with KUT 90.5, Austin's NPR station. And this is Now What? A series of live streamed events from KUT in partnership with the University of Texas at Austin and the Dell Medical School, focusing on what comes next as we deal with what the coronavirus pandemic means for our lives now and in the future. Each week, we're talking with scientists, researchers, and thinkers from across UT Austin to get the latest about COVID-19. This week, we're talking with Dr. Parker Hudson. He's an assistant professor of internal medicine and infectious diseases at Dell Medical School. He leads the contact tracing team at UT Health Austin, the clinical practice of Dell Medical School, and he serves on the governor's strike force to open Texas, to reopen and restart work, school, entertainment, and culture in Texas. And if you have questions during our discussion, you can write them in the comments on Facebook, and we will try to get to as many of those as we can during the conversation. Dr. Hudson, thanks so much for taking the time today.
Thank you. I'm very, very happy to be here.
So first of all, if you could just define contact tracing, exactly what is that?
Right. So contact tracing is a very sort of basic, a fundamental public health intervention to stop the spread of an outbreak or an epidemic. And what it entails is finding people who are infected with, in this case, a virus, which become, quote, cases, and isolating them to separate them from society temporarily, at least physically, hopefully not socially, to protect the public from that contagious disease. And in doing that, we ask them for who else they could be in contact with. And then we follow up with those contacts, and those people we are assessing to see if they were exposed and exposed in the right way, depending on the infectious diseases, which in some cases of contact tracing may be a sexually transmitted infection. In this case, obviously, it's primarily a respiratory infection. And then we ask the exposed people, if they were exposed during the infectious period of the virus, to quarantine themselves, again, to separate from the rest of society temporarily, to monitor themselves to see if and when they become infectious, because they were exposed to a known, to the virus.
And we're going to go through and kind of break down that process into pieces as we're talking about this today. But I thought it was interesting that contact tracing is actually not a new tool. We've been hearing about it a lot in relation to COVID-19, but tell us a little bit about the history of contact tracing and circumstances where it's been used before.
Yes, it is a tried and true, and one of the few clear interventions we have as outside of shelter in place type orders. Obviously, social distancing, masking. These are the other important sort of public health efforts that we can come back to. But beyond that, it is a very sort of basic approach to public health and has been used for a long time for tuberculosis. It had a part in the eradication of smallpox. It's used now related to sexually transmitted infections as far as HIV and syphilis. When we have individual outbreaks of, say, Legionella or some other, a mumps case or measles case, public health organizations have been doing contact tracing for specific outbreaks like that, and for more continuous epidemics like HIV for a very long time. most recently, it's been used and shown and was very effective in controlling SARS, the previous form of coronavirus. That through contact tracing, we really were able to contain and then eradicate SARS, right? Because we were able to break the chain of transmission. If infected people are known and aren't able to pass it on to other people, and those people that were exposed are also protected from passing it on to other people, the virus can't propagate itself. It can't keep going, and thus we haven't seen SARS in 15 years. Likewise for MERS, and then most recently for Ebola, it played an important role in eradicating or controlling the 2014 Ebola outbreak in West Africa. So a lot of rich history. WHO, CDC, state and local health departments all have sort of experience, protocols, guidelines, and expertise in what is a fundamental public health response to a pandemic.
And in all of those cases, the role that it's playing, as you said, is it's breaking the chain of transmission. So you're sort of intervening or interrupting the possibility of further spread by finding out all of the contacts. I think it's called an index case. Is that right? That
Yep.
original case?
Yes, that's exactly right. And again, the idea is really in one of the fundamental pillars of contact tracing, and ultimately something that is I think challenging right now in our society, in our polarized society, is that it really depends on public trust and the public support that we believe as a society, whether we're talking about Austin and we want Travis County to act this way together, that we are all safer, our loved ones are safer, our businesses will be better off if people who are sick stay home and are isolated, and people who are exposed stay home or are quarantined, so that the rest of us do reopen sort of the freedom to move about society ideally with masks and social distancing.
Well, let's talk about the process now a little more of contact tracing. What exactly goes on? You've described you've got that index case, and then you ask them for all the people that they've been in contact with. What is the timetable for that contact, and what kind of contact does it have to be? I think you said they have to have been exposed in the right way. So,
Yeah,
what does that mean, in the right way?
right.
Who are you looking for when you're looking for those contacts?
Right. So these are all really, really great questions, and I hope people understand the process more, and hopefully we can build support for this. So it really starts with that test, right? So a positive test comes back, and I should say, and I should back up, especially with the introduction. UT has a contact tracing partnership with Austin Public Health, right? Contact tracing, like I keep saying, is fundamentally a public health responsibility and intervention. But early in this, in our local epidemic, we were able to partner with Austin Public Health to have designated authority to basically, because of how labor intensive it is, to quickly bring online our group to support the city's efforts in contact tracing. And so with that, a lab report, from either our own clinic or from the city that includes, a positive case, really triggers the process. And so with that, we call, the person, the patient or the index case back, and we start to ask them questions about, obviously part of it is just the human interaction of checking on how they're feeling, what things that they need as far as immediately, potentially even medical care, or additional needs that they could have while they're isolating at home. So we try to work through some of those barriers to how you could effectively isolate yourself at home, educate people on what isolation really means and what that looks like. So that's part of the conversation, right? We want, and that's where the public trust is important, and that it's really about people collaborating with people to achieve this goal. And then subsequently, we start to find out more about their symptoms, when their symptom onset was, which helps us define the infectious period. So we've learned a lot since you and I first spoke 3 months ago, and we really have narrowed it down that the infectious period is best described as about 2 days prior to the onset of symptoms to 10 days after the onset of symptoms, assuming that your fever has broken and your respiratory symptoms are improving. So that is then defined as the infectious period, and we try to determine who they were in contact with during that window. And contact has also evolved over the last 3 months, and I think some of these definitions are why there's some mixed messaging out there. But we are learning that it is a slightly more, a longer definition of contact, around 15 minutes of close contact within 6 feet. And so that's where the social distancing comes in, maintaining that distance for the droplets that can come from speaking, coughing, sneezing, yelling, singing, I think I said. So that distance is protective from being a close contact.
This is Now What, a series of live streamed events from KUT in partnership with UT Austin and the Dell Medical School, focusing on what comes next as we grapple with what the coronavirus pandemic means for our lives now and down the road. And today we're talking about contact tracing with Dr. Parker Hudson. And Parker, I want to ask now, so you said we call somebody when there's a positive test. Who is we? Who is actually doing the calling and the interviewing in contact tracing?
Yeah, and let me again back up one phase. I think myself, the city, the state, many people feel like contact tracing, like I said, is a human to human, interaction to be done most effectively. There's a lot of discussion around technology and apps that can help do some of the tracing, including the Bluetooth technology and geolocalization. And that is not, the we is not a robot or, an eye in the sky. The we are UT employees and staff who have been, reassigned, have offered to be reassigned to support this effort, while normal operations are not in effect. In addition, we have volunteers who've been trained, have agreed to a level of privacy and security to be able to do this work as public health, as public health professionals. So we that is our current pool of we. Obviously, Austin Public Health has an entire epidemiology division that they're also building and growing, who is the we for Travis County as well. And I'll stop there.
Well, and you kind of alluded, Parker, before in describing contact tracing. It depends a lot on people being very forthcoming with where they've been, who they've seen, what they've done. Now, obviously, when we've been under sort of more of the stay home, work at home rules, that hasn't been quite as difficult to do because people didn't have as much contact, but businesses are opening up. People are starting to be out and about more. If somebody attended one of the recent protests or demonstrations and then they test positive, I mean, how on earth do you do contact tracing for somebody who was around a lot of people and they don't even know who they all are?
Yeah, that is a particularly challenging situation, especially outdoors in places that you may not know all the people around you, which is where some people in some other countries have advocated for use of sort of the Bluetooth technology to be able to collect and identify those people more rapidly. We are not doing that, to be clear, and realizing that we may, we likely are missing people in that large environment. And that environment, I think it's more about the messaging, making sure that you're rapidly getting tested, and that the contacts that you do have are identified and also contacted for testing and for quarantine.
Parker, I wanted to ask you, we had a question from an audience member that relates to, you mentioned earlier, that infectious period, sort of that specific amount of time when you're looking to see if somebody had contact with that original case, that index case. And the question we had from Eileen in the audience is, how fast do you need to reach the contacts of that original case for contact tracing to be effective? How fast do you have to work to start tracking people down?
Yes. The faster the better, right? So that's a great question. And we ideally, and the whole reason why people have been proponents of using technology to assist this process is because you would want it to be almost instantaneous, or immediately, without delay, that comes from trying to call people. And so our goal is to reach is to try to reach when a lab comes in of a positive person who then will be investigated as a case, is to reach them that same day. And when we have their once we have their contacts, to at least text them that that you potentially were exposed, and that you will be receiving a call, and you should avoid going out until further discussion. And then we try to call people 3 times to reach them. Now, different models have suggested different levels of speed and coverage needed to truly control the epidemic, meaning through contact tracing alone, have the epidemic die out. And so ideally that would really be within 48 hours, and would have fairly complete, likely over 80, even 90% of contacts reached. Now, that doesn't mean, again, in the all or nothing, it's not an all or nothing. And so any amount of cases that we reach, contacts that we reach, drives down the potential transmission and the potential for exponential growth throughout our society. So it's, as always, a complicated answer. The bottom line is, the faster the better.
That's got to be quite a text message to receive, to get a text that says you may have been exposed to COVID-19, or you were in contact with somebody who's tested positive. Yeah. That's quite a text to receive. Does something usually come along with that? Is there a number that people can then call right away if they want to? Because that can be pretty jarring news to get by text.
Yes, exactly. Again, we're always trying to balance that, the need to get information out there quickly and the need to deliver it, carefully. And hopefully by, being accessible and following it up with person-to-person phone calls to make sure we're addressing needs and answering questions, rather than just letting technology just link people up completely independent of human interaction. You got exposed, go here and get a test, without any ability to, engage somebody. We've preferred the opposite approach.
So you have mentioned technology a few times, and that's certainly one of the tools that can be used in contact tracing, as you've described. But you've also said that human-to-human interaction is preferred. People can ask and answer questions. But isn't there an advantage, though, to the speed of some of that technology, especially, in places like Texas, where businesses are reopening, cases are increasing? I know you want that human-to-human interaction, but isn't there an advantage to the speed of an app?
Yes, absolutely. And then some would also say possibly a cost, right? We've said how labor intensive contact tracing is, which has been one of the main criticisms, is that it may at the scale that is reportedly needed for coronavirus, it may not be the most cost effective approach. One of the issues is that it's one of the few, I think, proven approaches, and until we have vaccine, better treatments, et cetera, I personally think it's definitely one of the best strategies. The role of technology there, I think could be to supplement. Technology also has its limitations. So it's really the ideal state is probably having them complement each other, and I think that is the direction that things will go. Technology used on a voluntary basis. Some people don't access technology well, or just have access to it at all. And technology is a little bit more of a passive process. It's like, oh, do you want to respond to this and say load in your contacts yourself, versus have someone really work through the infectious period, try to jog your memory of all your potential contacts, as more of an active process. So they're probably complementary, using the speed of technology with the trust of a public health professional.
And Parker, we have a question from Marianne Castro, who is watching on Facebook. Here's her question. She's curious how word gets out. So here's the scenario that she paints. So say if she's at a restaurant on a certain day at a certain time, and someone else there is infected and winds up testing positive, how do people get notified then who were there at the same time? I think another way to ask that question is, what if you're a contact of someone and they don't know who you are? You're at a restaurant, you're eating lunch, and then you get symptoms, you get a positive test, and you can say that I was at X restaurant on this day at this time, but there's no way to reach necessarily everybody who was there at that time. How deep does the process go to find out who the other patrons were?
Yeah, that is definitely one of the challenges. Two issues there are that remember, the definition of prolonged close contact is really within 6 feet for 15 minutes, and so it's mostly the people that you're dining with. Possibly there's somebody else in the restaurant, or in a nearby area that could be could meet that definition. The scenario of having to notify people of anybody who is in the restaurant in a given time period is more for truly what we call airborne diseases, which are really measles and tuberculosis. And that's why there's been so much attention to whether this coronavirus is truly spread through airborne, gets aerosolized, lingers in the air, and anybody who walks into a restaurant hours later could be infected. And it is, the epidemiology does not suggest that is a significant contribution to the spread throughout our society. So that's why you're not seeing massive sort of public notices. If you entered this restaurant on this night, you could have been exposed, because that, for this virus right now, that does not seem like a necessary strategy.
You're bringing up an interesting point, Parker, because what I'm thinking is, for a disease like COVID-19, we're still learning a lot about it.
Yes.
And how flexible is a contact tracing system? In other words, how often can questions be changed? You're training lots of people to do it, but as you learn more about the disease, maybe that infectious period changes,
Right.
or maybe the transmission information changes, yes, and you've got to go back and change questions. That seems like that could be a long and maybe cumbersome process. If you trained contact tracers, you've got to go back and train them again then as the information is updated.
Yeah, interestingly, it's we're able to update our training modules and our contact tracing contact tracers quite regularly. We take our direction from Austin Public Health, who leads this for our city, and so they've made changes appropriately to adapt to like you said, new questions that should be on a case investigation form. And so as those changes come, we update the process. Interestingly, one of the more challenging things has actually been the technology side is often harder, as far as updating applications and data fields and data pulls, and that's been one of the challenges for the whole country, including the state, and our area, is how to effectively be able to share, data, especially as the data fields and are constantly changing.
You mentioned Austin Public Health, and we had touched on this earlier, but just to explain again, what is the relationship between Austin Public Health and their contact tracing efforts and Dell? You're leading Dell's contact tracing efforts. How does that mesh with or overlap with Austin Public Health's efforts?
Yeah. So we are a designated, we're a partner, and everything we do is underneath Austin Public Health, who leads and is in charge of contact tracing. So we marry our protocols, and we're basically collecting this data and serving our community, and then sharing that, with Austin Public Health, that data.
So we had a related question from Raven in the audience who wants to know, how do you get a job contact tracing in Austin? If you
Yeah.
want to do that and you're looking for a job, I know Dell was looking for volunteers. What is the status of all of that right now
Right.
as far as jobs or volunteer
Yes.
opportunities?
Yeah. Thank you. We've had a wonderful volunteer workforce, and we have thankfully we have a deep pool right now of volunteers who we're bringing on board, as cases grow, as the opportunity, as people rotate off, and we need more, and we need more support. I think ultimately, for this is not unfortunately going away, and for a sustained response through the summer and fall, and possibly and then winter, we hope that the workforce can become more of a permanent workforce with funding and paid. Obviously, people looking for jobs, this is a great opportunity to work to support the control of COVID. So those positions are still being worked out, and in the meantime we continue to use volunteers.
You said this is going to be a long effort, the length of the pandemic. How long does it make sense to keep up contact tracing efforts? Is that always a useful tool, or is there a ceiling of case numbers or a rate of case growth where there's just not the person power
Yep.
to continue those efforts?
Right. Well, for example, it's another great question. These are all great questions that there's not specific answers to say a specific threshold. If you have 1,000 cases, you should stop. For example, if we suddenly had, if we went from 100 cases to 1,000 cases tomorrow in Austin, that would be the end of it, right? We couldn't scale fast enough, but we would scale and try to catch up on the backside. So at some point you're not able to keep up as it spreads, but as things come back down, and this is why contact tracing has got so much focus, as things are coming down, you can help speed the recovery, and then prevent that second wave, right? So everyone's talking about that second wave. As things get under control, or in this case, as we're reopening, the more contact tracing we have, we try to we'll try to prevent that uncontrolled spread. If we ever get it actually down, like in some countries where we have cases in the teens, it'll still take aggressive contact tracing, because it will consistently try to pop back up until we have a vaccine. Now, just to remember, we're in the 3,000s for cases, even up to I'm sure we'll be at 4,000 soon. Even if that is an underrepresentation of cases, even if it's fivefold, and there are actually 20,000 cases in our area, that's a tiny fraction of the population who are all susceptible to this virus. So, we have a long way to go, a lot of susceptible people. And so I see contact tracing playing a role in some capacity, throughout this epidemic.
And that case number that you were quoting, that's for Austin Travis County. I think we're just under 4,000 right now till the numbers come out a little bit later today.
Thank you for clarifying that. I don't want to misquote numbers.
So I guess I want to sort of flip that question a little bit and look back as the state started to look at reopening businesses and trying to sort of get the economy started again, part of the mission of the strike force, and you're on the strike force to open Texas, was to comprehensively test and trace COVID-19. I'm curious if you know how much contact tracing had been done before businesses started to reopen, how widely that was being done around the state.
Yeah. So um, contact tracing has been done again at the local at the local level, just like Austin Public Health leads our efforts. So, local health departments have had various responses and capacity for contact tracing, and it continues to be, I should say, ultimately the responsibility does lie locally. I think the state structure is able to help fill in places where they don't have a local health department, and support or augment local health departments depending on how they want to engage with the state. I think ultimately the questions of the state's program are probably better suited for Department of State Health Services dishes, and then the governor's office.
And just as we wrap up, Parker, I kind of want to ask a little bit more about the process itself. We've talked about people may have privacy concerns who are contacts of that index case, that sort of original case. Just to demystify the process a little, can you tell us what some of the actual questions are? If I get that text that says you are a contact of someone who tested positive, please call us or we're going to call you. If I get that call, what kinds of questions would I get as someone who's being contacted?
Yeah. So it is initially, the initial questions, obviously confirming, is just confirming your basic information, but it's really to check on symptoms, right? So the whole point is, after you're exposed, you're now in the incubation period. And I think that's one of the things that's confusing, right? We talked about the infectious period. So somebody who is sick with coronavirus, what's the time period in which they can spread that to somebody else? And that is different than the incubation period, which is once you're exposed to coronavirus, how long until that infection until you get an infection, and likely symptoms of that infection. And that is usually between 2 days and 14 days after your exposure. So somewhere in that window. And on average, it's around 5.5 days after you got exposed to somebody, you will develop symptoms of having coronavirus if you're infected. And so we try to confirm that exposure, and then really try to find out whether people are symptomatic, and thus are then become cases themselves. And because that changes the type of recommendation we're going to be giving them, right? So we need to make sure then they know about isolation and the duration of isolation and how to achieve that successfully. Whereas the people who are exposed, we need to talk through how to quarantine till the end of that incubation period. In addition, for close contacts, we are getting people back in for testing. And so part of the conversation will be trying to is to offer testing and try to determine the best way and the closest way to get you a test for coronavirus.
This has been Now What, a series of live streamed events from KUT in partnership with the University of Texas at Austin and the Dell Medical School, focusing on what comes next as we grapple with what the coronavirus pandemic means for our lives now and down the road. Today, we've been speaking with Dr. Parker Hudson, an assistant professor of internal medicine and infectious diseases at Dell Medical School in Austin, and he leads Dell's contact tracing efforts. And Dr. Hudson, we thank you so much for your time and discussion today.
Thank you so much.